Hi guys, so I did enteroviruses for mine, and here I just did a little introduction. So enteroviruses were classified into four subgroups. There's the polioviruses, the Coxsackie virus A, Coxsackie virus B, and echoviruses. And then in 2019, genetic studies led to the reclassification of 15 species of the enterovirus genus into enterovirus species A through L and rhinovirus species A through C with multiple subtypes, or also called serotypes. Members of the enterovirus genus mutate and recombine easily within species. So there's always hybrid and variant enteroviruses continuing to be identified. The poliovirus is complex and has been mostly eradicated worldwide. This is why a lot of times when we're talking about enteroviruses, it's mostly non-polio viruses. We can thank the vaccine for that. And some of the most common symptoms are mild URI, which can include like a sore throat, fever, vomiting, diarrhea, anorexia, abdominal pain, rash, and headache. And then even just a fever can be the only symptom. And fevers we know can also cause myalgias, malaise, and irritability. And then some of the more uncommon symptoms but can occur that are more serious. We have cervical adenopathy, skin rash. This rash can be macular, maculopapular, urticarial, vesicular, petechial, and it can imitate the rash of meningitis, measles, or rubella. And then we also have herpingina, which is a sudden onset of high fever around like 106, and this can last 1 to 4 days. There's also loss of appetite with this, sore throat, dysphagia, vomiting, abdominal pain, and small vesicles can appear in a large to ulcers on the anterior pillars of the fauces, the tonsils, uvula, and pharynx, and also the soft palate. And then we can also get hand, foot, and mouth disease, aseptic meningitis. And then for diagnosis, we use the PCR test, or we isolate the virus in cell culture and then test with the PCR to identify the virus. The samples can be collected from stool, rectal swabs, respiratory specimens, blood, CSF, or from the fluid drainage of blisters. So the mode of exposure is typically the fecal oral route. This is by poor hygiene, dirty diapers, usually in daycare settings, ingestion via contaminated food and water, contact with infected hands, and also inhalation of infection aerosols. So right here, I just have a diagram. These are the phases in the Coxsackie infection, how it gets into the body. So first you have the ingestion of the fecally contaminated food or water with the virus. And that goes in, the virus grows in the intestinal epithelial cells and then enters the bloodstream. This is where the virus will replicate in the heart tissue, which can cause the myocarditis, or it will enter the central nervous system, which causes meningitis or paralysis, and also can enter the brain, which causes encephalitis. So some ways to prevent exposure, we want to wash hands often with soap and water for at least 20 seconds at a time. Avoid touching eyes, nose, mouth with unwashed hands. Avoid close contact, such as kissing, hugging, sharing cups, or eating utensils with people who are sick. We can also wear masks when in close contact with someone that's sick. Cover your coughs, sneezes with a tissue or a shirt sleeve, not your hands. And clean and disinfect frequently touched surfaces such as toys, doorknobs, cell phones, especially if you know someone has been sick in that area. And stay home when you are sick and keep sick children out of school so that we don't spread it. And also the polio vaccine is going to help prevent. And here I just have the polio vaccination schedule. So we get it at 2 months, 4 months, between 6 and 18 months, and then 4 to 6 years. So treatment after exposure occurs. Treatment is supportive. There's no medication for these viruses because it is a virus and not a bacteria. So we do aim to relieve symptoms. This will be by drinking enough water and electrolytes, over-the-counter cold medicine, and rest. And here I have Pedialyte because that's a great way to get kids to drink and keep up with their electrolytes. And then people with more serious infections will need more intensive support. So this is when people will need to go to the hospital. Antibiotics are only given for a secondary bacterial infection if it is suspected alongside the enterovirus. Like I said before, these are viruses, not bacteria, so there are no medications, but it is possible for the patient to get a secondary bacterial infection. So current clinical practice guidelines, enteroviruses present in numerous forms. So providers need to recognize the red flags for the more serious disease progression. And our primary care clinicians should educate the patients and their caregivers on the transmission prevention, such as hand hygiene, social distancing, what we talked about before. And patient education should include the ineffectiveness of antibiotics or other prescriptions to treat these illnesses. A lot of people think, oh, I need an antibiotic because I'm sick, but we need to teach them that this is not a bacteria and that those will not help. Providers need to prevent viral transmission by utilizing standard contact and droplet precautions as appropriate, and by encouraging that the child get these vaccinations and take steps to prevent disease transmission from provider to patient. And here I just put the CDC recommends that children get 4 doses of polio vaccine. So they should get 1 dose at 2 months, 4 months, between 6 and 18 months, and between 4 and 6 years old. And here are my references, and that'll be it. Thank you very much.